Courtney Venegas. I'm a fourth-year neurology resident here at Nebraska Medicine. Today we're going to be talking about stroke, and particularly stroke in women, and the disparity between men and women in their presentations, their treatments, and their long-time mortality and functional outcome. So to get started here, we're going to talk about, first of all, the anatomy, the cerebrovascular anatomy, to get us introduced. We'll chat about the steps through the stroke stop and admission and what goes on. And then we'll talk about risk factors for women, pregnancy and postpartum risks particularly. And then we'll also run through some cases that actually I was able to work with. So first of all, going on the cerebrovascular anatomy, I wanted to chat first about the circle of Willis. Here, this is an important thing for us to kind of visualize whenever we see someone coming in with stroke syndromes. We have our posterior circulation and anterior. Posterior circulation is mostly served by the vertebral arteries, which go to the basilar artery here. And the vertebral arteries come through the neck, and the basilar here feeds mostly the brain stem, but also gets some of the deep structures inside the brain. And then it goes into the posterior cerebral artery, which feeds the back of the brain, the occipital lobe, things like that, which I'll touch on. And then it also is a big proponent of feeding the cerebellum. The internal carotid arteries then make up the majority of the anterior circulation, and this branches off to form the middle cerebral arteries, which feed the majority of the brain on both sides, as well as the anterior cerebral arteries, which really kind of supply the frontal lobes most specifically. Together, though, we make this circle of Willis, which is important, as I will later discuss, because if one side goes down, often we can feed it by going through this pathway kind of reversely. I wanted to talk about the structures of the brain and the main lobes and their function, just so we get an idea as well for stroke syndromes. Here in orange, we have the frontal lobe. Main functions of this is motor control. We have that premotor cortex here, which controls our body and our motor functions, our problem solving, a lot of our personality, speech. Temporal lobe in pink is the auditory processing, our hearing. It also is involved in language comprehension. And then if there's a lesion, it talks about this Wernicke's speech production, or Wernicke's aphasia, where they talk and they're fluent, but they don't really make sense. And then we also have memory and information retrieval here. The blue here is the parietal lobe. This has that somatosensory cortex here. That is where most of our touch and our sensory information is perceived from our environment, and it also helps us know where we are in space. Occipital lobe here in green is mostly for our vision and our visual processing. Our cerebellum in red is for our balance and coordination. This is what I was talking about, that the basilar helps feed. And then same here with the brainstem in yellow. That is what controls our functions that we need to survive: breathing, our heart rate, our temperature, etc. I liked this slide. It again is chatting about the different lobes of the brain and their function, but it talks about how the dominant side and the non-dominant side have differing functions at times in the same lobe. And so to talk about the parietal lobe, as we know and just discussed, the parietal lobe deals with sensation and knowing where we are in space. But often, if we hit our non-dominant side, we have what we call neglect. And so that is where not only do we not feel on this left side of the body, because it's opposite with the brain, the right side controls the left side. So not only if we hit that right or the non-dominant lobe do we have a lack of sensation on this left side, but we kind of neglect or even ignore that whole side of our body and of the room, etc. And so that just is one example of how it is different. Another example would be if you hit the non-dominant side of the frontal lobe here, would maybe have personality changes and things, but our speech should be fine. But if you hit that dominant side on the left side, now I'm not able to talk. And then here, this is an important image that we're all taught, kind of in basics of neurology, neuroanatomy, and this is the homunculus. And if you look at the brain, we kind of laid over the body here. The body is laid over as the brain goes. So for the motor part, and it's different too between motor and sensory, but here on the motor strip, which is in the frontal lobe, it's kind of before that major sulcus here, that deep groove in the brain. You see though on both that the legs kind of hang over in the midline, and then the body kind of stretches over, and as we get kind of towards the temporal lobe here, that's where, you know, the hands and the face, and as you'll see, we call it the homunculus because different parts of the body are represented differently. So if you think about it, you know, my leg is represented less in surface area of the brain because when I control the leg, you know, it's less fine movement, if I can say, whereas the hand has much more representation because you can do much more fine motor movements and things like that with the brain. And then of course here on the face, on both sides, you think about it and how much more you can sense with the face, the lips, the tongue, how much motor coordination you have to control your speech. I'm controlling, you know, my tongue movement, my lips, my cheeks, all those things. So it just kind of makes sense when you think about it, the homunculus and what's represented on the brain. All right, so now to stroke basics. Ischemic stroke, this is a stroke due to a blockage of the major blood vessels in the brain, as well as smaller vessels. And then it's either due to, like I said, this clot that forms and blocks the blood vessel, or an embolic where another part of the body sends a clot that again then blocks the blood vessel. And the mechanisms that are majorly cause these ischemic strokes include cardioembolic, embolic stroke of unknown source. So those are the two embolic things. So whether, you know, if we find a blood clot in the heart, then that's, you know, the explanation, or they have an abnormal rhythm and that sends a clot to the brain. That's the cardioembolic. But sometimes we can have what appears to be an embolic stroke and we don't really know what the source is. The other main ones are the large artery atherosclerosis. So that's when the carotid arteries or the big major arteries that I chatted about in that circle of Willis become narrowed. And then small vessel disease, and that's where these small little vessels that branch off the main vessels get blocked. Hemorrhagic stroke is the other type of stroke. This is due to bleeding in the parenchyma or the other spaces of the brain. The major mechanisms are due to uncontrolled blood pressure, ruptured aneurysm, so if there's kind of a outpouching here in the blood vessel, if you can imagine a little pouch there that then bursts and causes bleeding. Cerebral amyloid angiopathy, that's when the blood vessels get a little more friable and there's deposits in those blood vessels and just cause some breakage of those vessels and lead to bleeding or hemorrhage in the brain. And then if there's an underlying mass or vascular malformation. Of strokes, 87% and the vast majority are from ischemic causes, whereas the less percentage, or 13%, are due to hemorrhagic. Now, most of those are from the interparenchymal, intercerebral, or in the actual tissue of the brain, versus the subarachnoid hemorrhages, which are due to bleeding in between the space of the brain and the meninges, or the covering of the brain. Now, there is a type of stroke or stroke syndrome that are more common in women, and which is why I bring them up here, and those are the cerebral venous sinus thrombosis. So as I said, women are at a risk of suffering from this, and this is due to blockage or thrombosis development in the sinuses of the brain, and these are the veins that drain the blood from the brain. And the mechanisms of this often are hypercoagulability, so related to something that's either situational, such as, you know, being pregnant, taking birth control, or something that you're born with and maybe you don't even know. And that's something like antiphospholipid antibody syndrome, factor V Leiden, MTHFR mutations. And then these are interesting because they can cause ischemic or hemorrhagic strokes. So here we see that there's a blockage of this sinus, the transverse sigmoid, and obviously the positive arrow sign. So, you know, big thing in neurology and looking at scans is look for symmetry, asymmetry here, but it actually led to a hemorrhagic stroke in this case. But despite that, we still give them anticoagulation, which I know can seem a little confusing. All right, so now I wanted to walk through the typical steps of the stroke activations here at Nebraska Medicine. First things first, stroke page is activated. We get that on our pager. We come to the stroke stop in the emergency room, and we do the NIH stroke scale. We then try to get to the patient to the CT scanner within 5 minutes. And we usually do our CT head without contrast, look for any kind of bleeding. And from there we do a CT angiogram to look at the blood vessels and the perfusion, which looks at tissue that's at risk for death or for ischemia, and tissue that already has unfortunately died. We then decide quickly, is this patient a candidate for TPA or TNK? And then if they're a thrombectomy candidate, we then either take them back to the ER room if they're not a candidate, or if they're going to get that blood thinner, or they go right kind of back to the angio suite to get that thrombectomy done. And just to show you the NIH stroke scale, it can range from 0 to 42 points, so there is quite a broad array, but I want to be cautious in saying, oh yeah, if you have the 21 to 42, that's a severe stroke, because I might have a patient present with an NIH of 3, but it's only due mostly to aphasia. But they can't talk, they can't understand you. I would consider that severe. But those are the main portions are, we're looking at the level of consciousness. Are they alert? Can they answer questions? Can they follow commands? And then, look at their gaze. Are they looking to the side? Is it forced, or can they kind of come back to midline? Do they have facial weakness? Do they have weakness in their arms and their legs? And then we look for, are they clumsy? Do they have some ataxia? How's their sensory, how's their language, and then kind of that one thing I talked about, do they have some of that neglect to where they are in space or to even touch and in vision as well. Now I wanted to chat about women in stroke, and so we can't do that without talking about epidemiology and statistics. So to discuss, stroke has a very large impact on society, as we know. More than 9 million stroke survivors in the US are living now, and we know every year about 800,000 people have a stroke. It's the 5th leading cause of death in the US, but of note, it's the 3rd leading cause of death in women. And about 55,000 more women than men have a stroke each year. The good thing that I want to mention, though, is that up to 80% of these strokes could be prevented with lifestyle changes. What we see here in kind of why maybe women are more likely to have stroke than men is kind of related to their age. So we see that the incidence in stroke and the mortality are similar in both sexes when you're less than 45. In this kind of middle range, 45 to 74, men actually have a higher incidence. But then when you're older than 74, women do. And we think that's often because women live longer. And then when we are older, we have some of the risk factors I'll go on and talk about that men don't necessarily have. And as I was saying, here we are, women live longer than men, and so 1 in 5 women will have a stroke. The proportion of deaths caused by stroke is higher in females than in males. And then in 2019, stroke was the 3rd leading cause of death in females, and at 6.2%, whereas the 5th leading cause of all death in males at 4.4%. And so this means that stroke kills 90,000 women a year. And then the rates of CVST among women in the reproductive age are consistently 3 times higher than that in men of similar age groups. So going on to stroke symptoms, I wanted to make a comment that, often it's missed in women as well, and that's why maybe there's some more severity in their stroke presentation and in what they develop kind of in the future in their lasting symptoms. And this is because they can often present differently than men. Of course, we still all have the same presentations of, we can have facial weakness, arm weakness, difficulty with speech, vision problems, imbalance. But women often can have just maybe some general weakness, which can be missed. I wouldn't necessarily think of that as a stroke either. If a woman presented with weakness, I think often they're written off as, oh, it's fibromyalgia, or there's something else going on. They can just be confused, disoriented, having memory problems, have fatigue, nausea, vomiting, etc. And again, also maybe even persistent hiccups, some seizures, fainting, loss of consciousness, neck pain, unilateral. And so again, this kind of shows a disparity between women being recognized as having a stroke compared to men maybe being recognized much more earlier. So it's not all doom and gloom. There are modifiable risk factors, but first I'm going to stick with maybe the doom portion and talk about the non-modifiable factors, and most of those is just age. Specifically, if you're older than 55, we can't control age, maybe someday, but not right now. Having a family history of stroke, the race and ethnicity, as I said, Black and Hispanic people have a higher prevalence of stroke and death rates. Gender, women have a higher risk of dying from a stroke, and then if you've had a prior stroke or TIA. Modifiable risk factors, though, here we are, hypertension. As you have a higher baseline blood pressure, your stroke risk increases. Normal pressure is less than 120/80, and so if your blood pressure is over this, it is abnormal and increases your risk for stroke. Diabetes doubles your risk of stroke. Cholesterol buildup increases your risk of stroke. Carotid disease, which kind of relates to all of these above it, definitely increases the circulation in the brain and can increase risk of stroke, whether that's from a piece of plaque, breaking off and blocking a vessel further down, or you drop your blood pressure suddenly and now you can't get enough blood flow up to the brain because you have that carotid disease. And then atrial fibrillation increases stroke risk up to 5 times. Lifestyle risk factors, so tobacco use and vaping. Current smokers have 2 to 4 times the risk of stroke. Heavy alcohol use, so this is greater than 14 drinks a week for men, greater than 7 for women. Weight and obesity increase the risk of stroke and cardiovascular events in general. And then physical activity. If you're sedentary, you're going to have an increased risk of stroke. And if you have a high salt and added sugar diet, that also increases your risk. Women specifically, and I'm kind of going to touch on this, but I have a couple maybe graphics that are a little bit better. But early onset or late onset of menarche or your menstrual cycle increases your risk. And that kind of goes with if you're on hormone replacement or even just your own endogenous hormone, exposure increases your risk for stroke. If you use oral contraceptives, that's about 2.5-fold increased risk of ischemic and also increases your risk of hemorrhagic at 1.4-fold. And then if you have early onset menopause, or if that's natural or surgically, if you need to have that done, that early menopause is a risk for you. And then pregnancy and migraine with aura. So in talking about this, we kind of chatted about the risks in women greater than men, but something I found interesting is even though men and women maybe even have some of the same risk factors, it seems like women still are having less favorable risks, if that makes sense. So basically what I mean is, here we have hypertension, migraine, obesity, men and women have those risks, but it's more likely to be seen in women. And then same thing here with hypertension, diabetes, atrial fibrillation, migraine, and smoking. And then because they have a higher risk, you'd think maybe we're getting on that treatment, but unfortunately it seems like even though they have these risks, they're less likely to get that anticoagulation for their atrial fibrillation, or they're less likely to get the statin therapy. So not only are they more at risk to have the classic risk factors for stroke, but then they don't get treated as well or as often as men do. And then unfortunately, say they do get diagnosed with AFib and we say, okay, we want to do a procedure to, decrease your risk of stroke, like the Watchman or an ablation to help, prevent those abnormal rhythms. Women have a greater risk of a procedural complication rate than men. And so it just seems like, unfortunately, things culminate into just a much better, not better, but a greater risk factor for women. And then, of course, we have the unique risk factors that men don't have, mostly related to, again, our own endogenous estrogen exposure. So, you have your menstrual cycle start and you have estrogen and progesterone and those hormones, with you your whole life until menopause and they decrease. But then also you have pregnancy, and if you more specifically have adverse pregnancy conditions such as hypertensive disorders, if you have preterm delivery, gestational diabetes, etc. And then again, this exogenous estrogen or oral contraceptives and postmenopausal hormone replacement therapy, those things increase your risk. And then kind of looking here at pregnancy specifically, in pregnancy, you have a change in just kind of your typical physiology. And so your blood volume increases, and so that leads to your, heart needs to pump faster, needs to work harder, and so sometimes that can cause stress on the heart itself and lead to some of those abnormal rhythms. And then you also, with pregnancy, just increase vasodilation, so your blood starts to pool, and then when there's stasis and pooling of blood, that increases your risk for clotting. And on top of that, you also have a hypercoagulable state, and that's related to some of these hormone changes leading to the procoagulant changes. So your factor 1, 7, 8, 10, 12, von Willebrand factor, all of these increase, which increase clotting at baseline. And then the anticoagulants that we naturally produce are decreased, such as protein S, and then your resistance for protein C. And then, of course, you have increased inflammation in the body, and so then that also increases your risk for clotting and things like that. The other thing, too, as I mentioned over here, is if you also, this is just baseline pregnancy and what happens, but if you have, abnormal conditions during pregnancy, HELLP syndrome, hypertensive disorder during pregnancy, gestational diabetes, all of that also adds on to the risk of pregnancy. What explains the difference between men and women in their stroke severity, their functional outcome, and their mortality? Well, I think big thing is their age. Women are older when they're having strokes, and so their pre-stroke functional status is probably less than, the 45-year-old male who's a smoker and has not taken care of himself. He was, although maybe not the healthiest person, was walking, was working full-time, all these things, and so maybe can just kind of come out on the other side of his stroke better, whereas my, 85-year-old grandma, she's been more stationary, sedentary, and although she's not as unhealthy, just doesn't have that reserve, that ability to kind of cope after she's had a stroke. And then specifically, as most women who are having the more severe strokes and are older when they're having their strokes, they have this atrial fibrillation. And so when they do have a stroke, they're having the cardioembolic, and that usually blocks the main artery, causes much more severe stroke syndromes than if they just had a smaller stroke in the middle part of the brain. And then, as previously mentioned, women are more likely to have those stroke mimics, and they're just not as easily identified. And so we don't get them to the hospital fast enough, don't give them that TPA, that TNK, or get them their thrombectomy because they just present outside the window. So again, like I said, it's not all doom and gloom. I think it's important that we promote that, with these Life's Essential 8, we can modify our risk factors, we can live a healthier life. So eating a healthy diet, getting 150 minutes of moderate physical activity, don't smoke, sleep 7 to 9 hours, maintain a healthy body weight, get cholesterol checked, keep your sugar less than 100, and keep your blood pressure under control. All these things can help us prevent strokes. And then I like this particular acronym, the BFAST, because I think it helps us remember that not all strokes are facial drooping and one-sided weakness, but that maybe there's some imbalance, maybe there's headaches, maybe there's confusion, the E for the eyes, blurred vision, more particularly loss of vision, like in one side of the body. And then, of course, including is my face drooping, is there arm or leg weakness, speech, and then getting people to the hospital as soon as possible. All right, so now it's time to go into cases. I know the thing that's more interesting to everybody. Here we have a 56-year-old female. Her last known well was around 3 a.m. on the 20th. She was acting weird around 3 a.m., kind of woke up, was confused, little off, but went back to bed. They thought maybe she was just tired. Suddenly woke up at noon and lost consciousness and became unresponsive. And so they took her to the ER, the local ER. At that time, she was intubated and sedated because she was, not responsive. She wasn't protecting her airway. And in the ER, they found her to have, bilateral pulmonary embolisms, and so they started her on a heparin drip. In looking at her history, she is on an oral contraceptive, but otherwise she's healthy, no other past medical history. There's a family history, maybe some lymphoma, but no clotting history, at least that we were aware of. And then she's a never smoker. What I'm going to ask you to think about what workup you would like to do. All right, so let's look at this CTA here. So here, looking at the aorta, as it goes up, it'll split here shortly into the common carotid arteries and then also the vertebral. So here are the common carotids and then the vertebral arteries here. And so this one might just be, her left one is a little more dominant. That's a normal finding in a lot of patients. But I want you to keep tracking this, maybe this right vertebral artery here. So we'll watch it here. It's going to go around. It's coming through. Now we're looking here, and it'll form the basilar artery. And then watch the basilar. And then you see here, I'm going to kind of rewind it a little bit. Okay, so here you can see, if you can imagine, that this is kind of still the vessel here, and now it's all gray. That is a giant clot here in the basilar artery. That's a very bad stroke syndrome to have. This is, again, that artery is feeding into the brainstem, and that's required for your basic functions of life. Okay, so after looking at that image, what symptoms do you expect with a basilar occlusion? With that, you would expect, like I said in talking about the brainstem, would expect, loss of consciousness, loss of ability to protect their airway. Often people have heard of the syndrome, locked-in syndrome, where they can't move anything, but they're aware, except moving their eyes up and down. That would be the most extreme version of a basilar occlusion, but often would think about weakness, think about consciousness, eye motor, movement, etc. Okay, so we brought her to the med center because we saw that she was out of the window for any kind of TPA, T and K, because her last one was 3 a.m. This is afternoon. So brought her to the med center for mechanical thrombectomy. So this is the initial angiogram. As you can tell, this is the vertebral artery coming up here, and you see the basilar right here, and then it just stops. So that again that's where that clot, that occlusion is. So here's the angiogram after they went in and retrieved the clot. Now I just wanted to show side by side what the before and after was for the thrombectomy. So over here we have the occlusion here at the top of the basilar, and you can see a lack of any of vascularization over here. And then after the thrombectomy, so much revascularization happened, and so here we have the basilar going all the way to the top. You have the posterior cerebral arteries coming off and all these other perforators to the cerebellum and things. And here I like to put this in here because it shows how much clot they got out of her blood vessels and related to that pen here. So it's pretty remarkable, really. So after she had the thrombectomy, she was admitted to the ICU. She was a Tiki 3. That just means that they got full perfusion after they retrieved the clot. That's the best you can get, which is amazing. She was started on aspirin and high-intensity statin after thrombectomy. She was found to have several hypodensities in other areas of the body, in the liver, kidney, and then she was found to have several, deep venous thromboses of the legs. I think also there was one in the arm. And so, as we knew beforehand too, she had these pulmonary embolisms. And so, because of everything that was going on, having multiple infarcts and clots in other places of the body, they did take her for a thrombectomy of the pulmonary embolisms as well, hospital day 2. And then after those big procedures, she was started on a heparin drip that night. She did also undergo IVC filter placement on hospital day 3, so a day after the thrombectomy of the PEs. She did have an MRI that showed a significant burden of ischemic stroke, including both thalami, the left midbrain, the pons, multifocal cerebellar, kind of that back of the brain, occipital, and then the left temporoparietal. And then when they did do some of our initial stroke workup, she was found to have a patent foramen ovale on the echocardiogram. And I just showed this MRI. It's kind of zoomed in and not the best quality, but it does show that both of her thalami were hit. And that also, when we talk about consciousness, there's only a few types of injuries that can lead to a lack of awareness and awakeness. And one of those is hitting both thalami. So I wanted to ask and have you think about what caused her stroke and what's your differential. And then based on that differential, do you want to do anything else for workup? So yes, thinking this is related to hypercoagulability. She had clots everywhere, so thinking about embolus, saw that that heart had a hole in it, and so it's possible that several of these clots could have come up in the right side of the heart, moved to the left, and then gone up to the brain. So, interestingly, found upon further questioning that she did have a significant family history of this factor V Leiden. And so that made us kind of dovetail into looking for other hypercoagulability possibilities, genetic ones as well, to figure out if she had those risks to increase her risk for clotting. Turns out, despite doing all of this, including some rare things like paroxysmal nocturnal hemoglobinuria, all of it was negative. We did do CT chest, abdomen, pelvis because we're looking for malignancy as well, because that can increase your clotting risks. Most of this workup was negative, but on CT chest, abdomen, pelvis, we did see some thickening of the lateral cecal wall. Did a PET scan. Again, this showed, increased uptake in that cecum. And so because of that, she did undergo some, colonoscopy biopsy of that and did find a tubovilus adenoma with high-grade dysplasia. This can eventually turn into high-grade adenocarcinoma. And so the thought is maybe this was kind of a perfect storm. Although she wasn't a smoker, she was on birth control. She had this underlying potential malignancy, and maybe all of that increased her risk for clotting, and then with that hole in the heart, that's why she had the strokes. So here we have a 29-year-old female. Her last known well was 12:45 back in November of 2023. She was at the airport when she suddenly could not speak, and she had right arm weakness. Her NIH stroke scale was originally 8 for aphasia and right-sided deficits. And then she did undergo CTA head and neck. There was no bleed, and there was evidence of a partially occlusive, that left internal carotid artery thrombus. For her history, she's healthy. She's not on any medications, including she's not on any kind of birth control. There's evidence of some hypertension and maybe a few stillbirths, which is interesting. Maybe that can maybe increase someone's risk for having a blood clotting disorder. And then she was a former smoker, but not currently. This is a CT angiogram. I wanted to talk about how she had that occlusion here of that left internal carotid. So I'm going to start it here. I'm a little bit higher up, but I want you to follow this left ICA. Here it's split off, and now you see it disappear. So if you compare here is her right internal carotid artery, and you can maybe see that over here is her external, the left external carotid, and you can tell it's external because it's got all the branches. And there's no ICA. If you can imagine, it's kind of here. This would be the left ICA. So it's completely occluded or blocked. However, if you keep going, you see here it came back. So that's the internal carotid. Now it's turning into the left MCA. And so she has that open, or at least recanalization, as we call it, or that, that importance of that circle of Willis is that if your left one goes down, your right can start to supply it, but just kind of through reverse flow. So she blocked that left internal carotid, but the right is supplying her left side of the brain. Now I want to ask you, would she qualify for any intervention? All right, so she was given TPA and admitted to the ICU. She went from having global aphasia and significant right-sided weakness and lethargy to being awake, alert. She had 4 out of 5 strength in that right arm, and the leg was completely back to baseline. She was able to say some words, but still having difficulty following complex commands. She, unfortunately, though, after some significant improvement, started having worsening in her exam. But then she improved back to the prior exam here once we kind of increased her blood pressure. They did repeat imaging, however, because of this fluctuating exam. And now we saw what appeared to be a complete occlusion of the left ICA. And it was irregular still, so we were concerned for dissection because, again, she's young. We didn't see a lot of that atherosclerotic disease or narrowing, but just kind of irregularity of the vessel wall makes us concerned for dissection or a tear of that vessel. She was kept in the ICU. Again, we wanted to augment her blood pressure, keep it more 150 to 170, whereas typically after you've been given TPA or you've had a big stroke, which would happen if you blocked that left ICA, that, we kind of lower pressure and keep them more normotensive. But we kept her a little bit higher, and then we did decide to pursue MRI because we wanted to kind of decide on what we're going to do going forward for prevention of more strokes and things to happen. And so MRI was fortunately negative for hemorrhage after getting the TPA, and she was started on aspirin antiplatelet therapy. So now I wanted to show you her MRI and compare a couple images side by side. This is where we look at images to see if it's bright on one scan and dark on the other. That means it happened acutely. We do know that this happened acutely because I've been talking with you about it, but I just think it's nice to see. So here you can see some of this area. This is a lighter color, and so that's part of where she's had infarct and maybe some along this cortex as well. But you can see on this one, it's much more bright and obvious, which is why we use this often for our screening portions of doing the MRIs and seeing if they're having acute stroke. Much more burden of disease you can see on this one compared to this one, and that's because this will just evolve with time. You just have to give that sequence more time to see the burden of stroke. So unfortunately, she had a significant event on hospital day 3. She had worsening of her expressive aphasia, and so they did call another stroke activation, and so she went to the CT scanner. And now I'm going to show you that CT scan from this hospital day 3. I want you to look at now her right side and look at the right carotid artery. that was what we knew, but now you see this one is starting to disappear. There. So this one is still gone. Now, we knew that. That was the one that she originally presented with, this left ICA. But you can see maybe some flow starting here, if you can imagine the contrast. And now we see this was once a nice round circular vessel, and now it's half gone. But then it comes back. So my question for you now is, what would you like to do? This is complex. She just already got TPA for the left one, but now the right one's starting to occlude. So we had, if you remember, just started her on aspirin after we had done that MRI and there was no bleeding. But because she's now having a second occlusion, we started her on a heparin drip without bolus. So that means often we bolus the heparin to get them up to a therapeutic dose more quickly. But in someone who's had strokes, we don't want to do that to decrease their risk of having hemorrhage in the brain. So we have her on aspirin and we have her on the heparin drip. We're continuing to augment her blood pressure with that goal of 150 to 170. We're continuing our hourly neuro checks. And then we discussed the possibility of doing a vascular intervention, like should we go in and, even stent or take out those clots? What should we do? She's clotting both of her main arteries that go to most of the entirety of the brain, both internal carotid arteries. That's a big deal. But after discussing, even performing this DSA, which just shoots contrast up into the vessels and looks, and doesn't mean you even do an intervention, in discussing with neurosurgery, they just really wanted to hold off because it seemed like she was having dissections and really just injuring her blood vessels all on her own. And if they did that, they could injure it on their fault, if that makes sense. So we discussed with neurosurgery the possibility of doing possibly a vascular intervention, but in chatting with them, it seemed despite all treatment that we could do, she was still dissecting on her own, and if they were to go in and do even just an angiogram where they shoot contrast, there's a risk of hurting that vessel wall and causing further damage, further strokes, so we held off. We also discussed, and because she was having further dissections of her vessel walls, we took her off the vasopressors and lowered the blood pressure goal instead of keeping her up higher because we thought maybe that was enough to cause some of this dissection. So we worked her up. Hypercoagulability workup was negative. We did a lot of autoimmune, infectious etiologies to try to think of why is she dissecting, why are her blood vessels so fragile. All of it, again, kind of coming back negative. There was no family history of connective tissue disorders. There's no, uterine rupture history since she had these histories of deliveries in the family of, the miscarriages and things like that. We also continue to have worsening exams where she would find to have more dissections or more occlusions in multiple different vessels. And so eventually we took her off the heparin, transitioned her to both the aspirin and Plavix. And then she fortunately was able to discharge to acute rehab. At the end, though, we found out that she had this, as she presented, she had the left ICA dissection leading to the occlusion or complete blockage. That right ICA, she had a pseudoaneurysm and partial thrombus, but it never fully occluded, which is good. Her vertebral arteries both had dissections and some thrombosis there as well. And then her MCA, those two vessels go into the hemispheres, and the ACAs that go kind of the frontal lobes, those also had infarcts in those areas, and then also in the deeper tissues of the gray matter of the deep part of the brain, all had infarcts. And so at the end, on re-examination at a clinic follow-up, she was found to have, the partial Gerstmann syndrome, which is kind of a syndrome involving the parietal lobe, don't recognize things as well. She still had a left Horner syndrome. That's the, drooping of the eye, pupils really small, and sometimes they can also have like a lack of sweating on that left side. And then she had this right upper extremity weakness, and most specifically, because of involving these ACA vessels and getting the frontal lobe, she had this abulia or apathy where she just had no motivation and wasn't herself. Okay, so here we have a 29-year-old female. She presented with 24 hours of nausea and vomiting and diarrhea that started in March of 2021. She subsequently, after this 24-hour period, had worsening headache over the next several days. She noted it to be associated with photophobia and phonophobia, sensitivity to light and sound. And specifically, she thought it was kind of in this right posterior region that she had the pain. She tried everything over the counter, it didn't work, and so she ended up going to the ER, about 5 days after she had this initial, probably flu-like infection. Her history, she does have PCOS, is obese, but no history of migraine, no significant family history. She does smoke about 5 cigarettes daily, and she's been smoking since she was 18. And then she also is on a NuvaRing. So, what is the top differential that you think of with someone with a new onset and severe headache? I would say the 4 I want you to think of are CVST, or thrombosis of those veins I chatted about earlier. I want you to think of subarachnoid hemorrhage. I want you to think of RCVS, that's reversible cerebral vasoconstrictive syndrome. That's where the blood vessels literally spasm. And then the last one is intracranial hypotension. So that's if you have a spontaneous leak or something of CSF, that brain sags. It stretches on those meninges or the covering of the brain and causes a lot of pain, really bad headache. So what imaging would you like to do? So yes, we're going to look at the MRV. Anytime someone has this severe sudden onset headache, you definitely want to look at their blood vessels in the brain. Often want to look at the veins as well. I'll pause it there. So you can see here on the left side that she has a vein here, but again, you're looking for asymmetry, and she's missing all of that on her right side. So after finding her cerebral venous sinus thrombosis, she was transferred to the med center. She was started on a heparin infusion and then IV fluids. As I discussed, her total burden of thrombus was her right-sided transverse sinus, sigmoid, and proximal internal jugular vein. Fortunately, on imaging, she had no evidence of a hemorrhage or ischemic stroke from the CVST. Her NIH was 0, which is good. On workup for any kind of increased risk for clotting, we really only found that she had a low B12, so we started her on supplementation. All her iron studies were normal. Hypercoagulable workup, again, all of this was negative. And so after being admitted for 3 days and getting heparin, she was transitioned to oral anticoagulation with Eliquis and sent home. Now I want to show you how her repeat MRV around 6 months later looks. So as you can see, this is the normal side, but then there's a lot more of that vessel here, and you can see it kind of again trace. That's the transverse, now it's sigmoid, now we're going into the internal jugular vein down here, and it's much improved. Although still not 100% back to what her left side is, it's much better. Here we have a 30-year-old female. Her last known well was August 6th at 12:30, and she started to have vomiting, had double vision, had decreased spatial sensation on the right side, as well as imbalance. She had noted she'd maybe been having a few days of neck pain and headache, It started about 4 days prior to this last known well. And so she had been laying in bed and did have some pain relief with Tylenol. But she ended up going on the 6th to the outside hospital ER to discuss her symptoms, and she was having worsening lethargy, and her husband was concerned. At that time, they did do a CTA of her head and neck and found out she had evidence of a right vertebral dissection and basilar occlusion. She declined at the ER, and so she ended up needing to be intubated, and so they sent her here for possible thrombectomy. Again, looking back, she was recently pregnant. She's 5 months postpartum now. So kind of outside of that typical window of like 6 to 8 weeks postpartum where you have that increased risk of clotting or stroke, as I talked about previously. And no family history of stroke or other neurologic conditions. She's a never smoker, really healthy young woman. So I wanted to show you her angiogram of her blood vessels as she came in for possible thrombectomy. There's that vertebral artery in her basilar. I'm going to play that again and pause it. So this, I would say this one is almost a little bit more obvious than that first basilar occlusion we had, our first case, if you remember so long ago. And it just is a very brief stop here. And you can tell, as previously, she's just not perfusing a lot of those blood vessels that feed the cerebellum, feed the brainstem, feed kind of those deep nuclei of the brain. So remind me, what are the symptoms of a basilar occlusion again? Is there any intervention indicated? I would agree. She's outside the window for any kind of TPA or TNK, but as discussed earlier, she should be assessed for a thrombectomy, and my angiogram maybe hinted at that. So I want to show you her angiogram after she's had the thrombectomy to show you the difference. As you can see, much better perfusion. I'll play that one more time. You can see it's all the way open here and going up. You can almost see the cerebellum. So for her, she did undergo that mechanical thrombectomy of her basilar occlusion. Again, she had TK3, was admitted to the ICU and remained intubated. She was started on a heparin drip and aspirin because when they were in there, they found out that her right vertebral artery had had that dissection. And in order to kind of get to the occlusion of the basilar artery, they had to place a stent. Anytime you do place a stent, you need to have an antiplatelet. Initially, on her first kind of examinations, she was unable to move her left upper extremity, and she was only intermittently following commands. We did end up proceeding with MRI to quantify her stroke, and she was found to have bilateral cerebellar infarcts and a right pontine infarct. They found, however, that she was developing some hydrocephalus compared to that CT head from the day prior, and so she went for an urgent suboccipital craniectomy and a C1 laminectomy plus EVD placement. What this means is our skull is fixed. If your brain starts to swell, which it will after you've had a stroke like this, then we need to put the brain and that swelling somewhere. And since we don't want the brain to herniate and go downwards, which causes permanent damage, we remove part of the skull. She hit her cerebellum, so they're going to remove the back of her skull here, and they also went into that top part of the cervical vertebra. And then they place that EVD, which is a drain that they place to help reduce the risk of swelling as well by removing some of that fluid, that CSF that is in the brain. Here I'm going to show the MRI of her strokes. On one image it should be bright, and then the other one it will be dark. So here you can see the significant amount of damage she had to her right cerebellum. There's a little bit here on the left. Just this cut is mostly showing that right cerebellum. And then same thing over here, it's dark. So again, it correlates showing that this was an acute stroke. And then here you can almost see the darkness on the pons, and that part of the brainstem had also been impacted by that basilar occlusion. On further imaging, after she had this EVD, which is extraventricular drain, she was found to have a tract hemorrhage in that right frontal area in the course of that EVD on imaging. Fortunately, though, despite that, she was able to be extubated on hospital day 4. So that was 2 days after the EVD placement in that, occipital, the skull removal. She remained in the ICU because whenever you have this EVD in place, you have to be in the ICU for close monitoring. And fortunately developed no signs of hydrocephalus, so they removed it on hospital day 6, 4 days after placement. She ended up being loaded with Plavix on hospital day 9, and her heparin infusion was stopped on the hospital day 10. She did stay in the ICU for several days, but eventually on hospital day 11 was able to be transferred to the floor, just on the DAPT. So for her, we believed her mechanism of her stroke to be related to artery embolism. This is kind of a nuanced maybe, or particular, going into the weeds type of mechanism, basically more so an embolic phenomenon. And it was due to the fact that she had that dissection in her vertebral artery that needed the stent. And so the wall was torn, caused inflammation, caused clot formation, and that flew up to her basilar artery to cause the occlusion. We aren't really sure why she had the vertebral dissection in the first place. All of her workup really was within normal limits, and she improved significantly, and fortunately just had a little bit of ataxia at the end and was able to discharge home. It's quite the recovery. It's pretty amazing. Well, thank you so much for listening. I was happy to be able to give this talk, and we talked about strokes as it pertained to women, and we talked about a few of these interesting cases and differing presentations. Hope you have a good rest of your day.